Welcome to the CME accredited podcast series, Rethinking PC-IOLs, From Evidence to Clinical Decisions. I'm your host, Dr. Jennifer Loh, a cataract refractive surgeon in Miami, Florida, and I'll be in conversation with leading clinical experts exploring the presbyopia-correcting intraocular lens landscape, from preoperative diagnostics and surgical planning to patient communication and financial considerations. Welcome back to our second episode in our series, Diagnostics that Drive Decisions. I'm joined here by our expert guest, Dr. Rahul Tonk, who is a cornea, cataract, and refractive specialist at the Princeton Eye Group in New Jersey, and he's also an associate professor of ophthalmology at the Wills Eye Hospital in Philadelphia. Thank you so much for being here, Rahul.
It is my pleasure. Thanks so much for having me.
Of course. So I want to dovetail on our excellent discussion previously about the underutilization of presbyopic IOLs and why that may be, to really dive more into now the process of identifying patients that could be good candidates for a presbyopic IOL, what testing to perform, how to analyze those tests, and also then how, most importantly, to select the right technology for the right patient. And even I'd like to touch on a little bit of how to manage some of those unhappy patients that we may have. So Rahul, first take me through how you first assess these patients. That's critical. That's critical.
Yeah, thanks, Jen. So I think, you alluded to one of the sources of dissatisfaction and maybe underutilization of presbyopia correcting lenses is having the wrong lens for the wrong patient that doesn't meet their lifestyle goals and that doesn't match with the health of their eye. And so this process is exceptionally important, and it really takes a good amount of time, and it's almost an art to customize a patient's vision, and you got to have a little bit of fun with that. So I think there are two components. One part has to do with the patient's lifestyle and what their goals are, and helping them communicate that in the best way possible. They don't understand these technologies. They don't even really think about how they use their vision and what their hobbies are, what their occupation is, what activities they do more or less. They need to be able to express that to us so we can understand what lens might be good for them. So the second piece then would be the actual hard diagnostics that help us measure the eye appropriately, screen out for other diseases that might complicate certain lens options. So starting first probably with lifestyle and expressing patient goals. So my patient journey with my patient starts very early, way before I ever see the patient in the exam lane. When a patient books a cataract consult with me, they'll have some information sent out to them that they can access on their own time. One of them is a very simple, low-tech video of me that is sent to them by email, which basically explains what a cataract surgery is, what it involves, that it involves a lens implant, right? Because what use is a conversation if a patient's learning about a lens implant for the first time in your cataract consult? Let them understand that a lens is going to be put inside the eye right from the get-go, and that there are options with respect to what lens implants that they have. Guide them then in that video to say, I want you to think about your eyes and your goals, and lead them through separate question and answer maybe that they ask themselves as they go through their life. There are some specific questionnaires. The Dell questionnaire is a well-known questionnaire by Steve Dell in Austin, Texas. I have a modified Dell questionnaire that I also have patients complete before they ever come in that expresses their goals. And so a patient, when they come to me, they've already thought through the fact that there are different options with respect to lens implants. They've also already thought through the fact that there may be some different financial obligation. I don't feel comfortable, honestly, surprising patients with that information in the time of a consult where I become a car salesman. I'd rather them know that they have options, and if they're interested in investing in vision correction, they can opt for that, and there are ways in which we can do that for them. And then I have, as soon as that patient comes into the facility, they're contacting my patient access team, my front desk staff, my technicians that lead them through. And my teams have been trained by me to identify little things that the patients may say or express that would lead them toward and away from any particular technology, such that when I sit down with the patient, I have really a very detailed, elaborate sense of already what that patient's goals are with respect to their cataract surgery.
That's amazing and so very helpful. It is impressive how much we have to gather from the patients in the short amount of time we have allotted for a clinical exam. So I absolutely agree with you. Doing work ahead of time, gathering those details and relying on your staff is critical. Like patients will tell your staff things that they may not tell you. So I think that's incredibly smart. So now that you've assessed, let's say fast forward, you've figured out the patient's lifestyles, hobbies, you've educated them that cataract surgery actually involves a lens implant, which is a really good point. We've all had those patients that ask us after the surgery if they had a lens implant. So it always worries me a little bit. But so right, education is key. Now let's get to the hard data. What diagnostic tests are you doing and what do you use? How do you analyze these patients from an actual medical perspective?
Right. So the next piece is to assess their candidacy for various lens implants. So we alluded to before certain when you extend the depth of focus, let's say with a multifocal full range of vision lens and partially with an extended depth of focus lens, you're trading off contrast sensitivity at the primary focal point for depth of field. So you want to make sure there's no other disease in the eye that's going to affect that contrast sensitivity. So if the patient has certainly glaucoma, if that patient has macular degeneration, that you want to be aware of that. I think a good, diagnostic dilated fundus examination, good slit lamp examination can tell you most of those things, but looking through a cataract at a macula is not always the easiest to pick up subtle macular pathology. And so one of my defaults for candidacy is an OCT, a screening OCT macula of the retina, which helps me to see if there's any macular pathology. Beyond that, I think ocular surface is really, really key. And you can go low tech, you can go high tech. I think super low tech would be making sure that every last patient that comes in has some fluorescein put in the eye and has a tear breakup time. And so if those tears are breaking up within 3 seconds, 4 seconds, you know that your tear film is unstable. And that could not only be a source of dissatisfaction for the patient after the fact, but it would definitely impact your ability to accurately measure that patient's astigmatism before you ever implant a lens. And so both of those things need to be optimized. And certainly you can do it with simple fluorescein, or you can use more advanced techniques. And one of my favorites, and what I do for every patient, is a screening placido disc topography. And that serves a dual benefit. It gives me first a qualitative idea of how that ocular surface is looking. Is the astigmatism regular or irregular? Irregular astigmatism, I want to look at the cornea and the tear film in a little bit more detail. And it also gives me a screening for astigmatism. Refractive astigmatism at the time of a cataract consult may be just a function of the lens. Absence of astigmatism may be the result of the lens counteracting a patient's corneal astigmatism, where the surgery reveals astigmatism that the patient wasn't aware that they had. So I think that screening topography is really very important, and I put it right up there with a good quality ocular surface examination, as well as a screening OCT of the macula in terms of figuring out, just in terms of hard diagnostics, what I need. And then, of course, you can get more advanced. You can do non-invasive tear breakup time, meibomian gland imaging. You can do tomography on top of topography if you have a Scheimpflug device. Certainly, you can do wavefront aberrometry. You can measure patients with various different biometers. We can get into utilization of front versus back surface measurements of the cornea with total keratometry. There's a lot of high-tech stuff that we can get into, but the reality is I think you get 80% of the effect with 20% of the work if you get a placido disc topography, OCT of the macula, and put in some fluorescein in every patient and just count their tear breakup time.
Absolutely. And I think you hit the nail on the head. These are all tests that most of us have access to, especially the fluorescein. And you're absolutely right. Explaining to the patients maybe why they actually have, or why they will have astigmatism after the surgery is important, because they may not have known that. And maybe it was because the lens was neutralizing the cornea astigmatism. So I love how you brought that up. I think that's a discussion I have every day with patients, and it's important to explain to them why. But yes, I think these 3 tests are essential. and most of us have access to. And then I would say like having a good biometry device is critical, getting those axial length measurements and using the right formulas. So that was a beautiful overview, very detailed. Thank you, so much, Rahul. But okay, now let's assume again, everything's perfect. Number one, you've identified the right patient, you've done the proper diagnostics, and we're satisfied with everything. The blessing and the curse nowadays is that we have so many great technologies, we have new options, but how do we decide now? How do we decide between an EDOF lens, a multifocal, trifocal design, a hybrid design? How are you picking? There's almost maybe too many choices now, right?
Right. And so, maybe let's break this down into lenses, sophisticated lens technology that corrects astigmatism, and then that extends the depth of focus. So the correction of astigmatism, first and foremost, is sort of aberration free, I think, in my view. We're not creating any loss of contrast. We're not creating any dysphotopsia with a choice of using, let's say, at a minimum, a monofocal toric against a monofocal non-toric lens. And so for many patients or many surgeons, the utilization of toric lens implants is their first foray into what some call premium IOL technology. And so properly measuring a patient's astigmatism, we talked about topography, we talked about biometry. We even sometimes will look at automated keratometry, refraction, what their habitual prescription has been in their eyeglasses before the cataract. All this data goes together to understand what the nature is, the magnitude and the axis of their astigmatism, and of course, optimizing their surface so that you get good measurements. Ocular surface disease management is critical for astigmatism management in particular. But in my view, any amount of astigmatism is worthy of treatment. We have an incredible, 10,000 eye study done by Julie and Steve Schallhorn that showed very clearly that astigmatism of even a quarter or a half diopter decreased the odds of getting 20/20 vision by about twofold. Astigmatism of 0.5 to 0.75 decreased the odds of 20/20 vision by sixfold. And so we definitely need to tackle even small amounts of astigmatism if we can, whether it is by using a astigmatism correcting lens implant like a toric, or by other means, astigmatic keratotomy with a femtosecond laser, manual limbal relaxing incisions, whatever you feel is appropriate. So that takes care of astigmatism. Now, astigmatism is especially important to be corrected in any lens that extends the depth of field. So when we're going into extended range designs like EDOF or full range designs like a multifocal, trifocal, or hybrid design, we know that these lenses are especially sensitive to residual astigmatism. So it is very, very critical to get that number right. When choosing then between an extended depth of focus versus a multifocal, let's say broadly, or a extended range versus a full range lens, it really comes down to goals and patient lifestyle and the health of the eye. Again, if a patient has from a contrast sensitivity standpoint, if the patient has pre-existing disease that's degrading their contrast, let's say mild glaucoma, maybe. I think some surgeons would say, I feel comfortable implanting a lens that minimally degrades the contrast sensitivity in this eye, and that would be something like an extended depth of focus lens. Or people would say, I don't want to take any contrast away. That is going to be a monofocal or monofocal toric or a light adjustable lens, let's say. Others would say, for mild glaucoma, I don't want to take presbyopia correction off of the table. I think what most people would then say is, well, I don't know about a full range of vision lens, right? That would be more contrast loss than I'm willing to offer my patient. And then, of course, the patient's involved in that conversation as well. If this is a patient that really doesn't have that much friction with eyeglasses in the first place, then, is it as necessary for them to trade off some contrast? And just keeping in mind, by the way, that these patients already have tremendous contrast loss from their cataract that they're coming in with. So most of these designs are going to be better than their preoperative with cataract contrast sensitivity. So that all has to do, that was an example for glaucoma, but that all has to do with contrast sensitivity. The next piece is going to be on, you could say, dysphotopsia. And this is where you really talk about what the patient's occupation and hobbies are. Is this a patient that's a commercial driver? Is this a patient that's a pilot? Is this a patient that's got to, drive across town to pick up her grandkids, several times a week, in Jersey winters where it gets dark early. So, those things would also kind of steer you away from lens designs that may indeed have some halo or starburst. So those two features, contrast and dysphotopsia, are the features that we need to speak to. It has to do with the eye health, and it certainly has to do as well with the patient's lifestyle goals.
Absolutely perfect. And I 100% agree with you. There's definitely categories we should think about. But like you mentioned earlier, getting to know the patient, what they need is also important, because sometimes we can have some wiggle room, but it really depends on us getting to know what the patient needs and lifestyle functions are. So that was perfect. Now we don't have much time left, but I know that one other big pain point for surgeons is how to manage the unhappy post cataract refractive patient. There's again not a lot of time. I do know there's a wonderful study by Kendall Donaldson showing that the two main factors for unhappy presbyopic lens patients is dry eye and refractive error, which is what you alluded to with the Schallhorn study. Any residual astigmatism or spherical aberrations are important. Do you have a few last words to say on that before we end?
Yeah, I think that there's a nice, workflow that allows us to figure out, what is happening with the patient. First, you need to have a good quality refraction, good quality look at the patient's ocular surface. And you need to understand, okay, well, if I put that refraction in front of the patient's eye, are they happy with their vision, right? And if they're exceptionally happy with the stability of their vision, then you can say that the problem is probably some residual refractive error. And so you might want to have some means of treating that residual refractive error, let's say with glasses or an enhancement eye surgery. If the patient has, let's say, glasses trial frames put on in the office and they're still unhappy, then you have to say, well, is it because there's an unstable tear film? Is it because there's cystoid macular edema, what have you, right? And then you look into those things and treating those things. But if the patient has excellent vision, is unhappy with the quality of their vision, ocular surface is pristine, and you've given them time to neurally adapt to their new lens implant, right? Then you also have to look at, was the lens implant technology the appropriate technology for them? And I think one other piece of comfort with presbyopia-correcting lens technology is having some familiarity with how to do an intraocular lens exchange. And I'm talking about a bag-to-bag exchange. I think just having that in your back pocket and knowing that you're able to do that will create a tremendous comfort level with starting to break into these lenses. How many bag-to-bag exchanges do I do in my practice for patients, for my patients, my presbyopia-correcting IOL patients? Very, very, very few. I try my best with preoperative counseling. I certainly try my best with postoperative management, but I very, very rarely or seldom have to do a bag-to-bag exchange because I've miscalled a lens. But having the comfort to do it and having the patient know, as you discuss some of the trade-offs with presbyopia correction, that they have, in a worst-case scenario, the ability to replace that lens implant, of course, with all the attendant risks to going back to the operating room, that will allow comfort on the part of the patient and certainly comfort on the part of the surgeon to be able to offer these lenses.
I absolutely agree. It's very comforting to know and feel confident that you can help the patient. So learning the intraocular lens exchange is very critical. Also, I'll put a point in for being comfortable or having a referral person that you can send to correct any minor refractive issues if appropriate with LASIK or PRK. So having access to, correcting a minus 0.5 or a plus 0.5, whether you do it yourself or send a trusted colleague, I think that's also important because that can be another source of dissatisfaction, those minor refractive errors, if you prefer to do that over a lens exchange. But sometimes a lens exchange is the best option. Well, this brings us to the end of our discussion. It's been a true honor and pleasure speaking with Rahul. I have learned so much from you, and I really appreciate you taking the time. Thank you as well to our audience and listeners. We hope that you join us for the next episode in our series entitled Mapping the Surgical Journey. Thank you again.
Thank you so much for having me.
You can explore all episodes in this series, along with additional activities in the full CME accredited program. If you're listening outside the program website, the link is in the show notes.